So this is my first time being here, and this is my first time talking about this topic. So we're just going to do it as a little bit of an experiment. I'm going to be talking about cancer in specific because my job is I work with the Montana Cancer Control Program, which is an awful misnomer, isn't it?
Cancer control.
I do not feel in my 3.5 years of being there that I've done anything to control cancer, but I have certainly learned a lot about it and have certainly been able to watch and see how things have changed even in that 3.5 years and beyond that. And so I thought we could have a discussion tonight about how dying with cancer has changed over the course of the years and kind of what some of the current issues are with specific cancer. And that's why it's so great to have Michelle here, because she is a top proponent with working with people. And so I'm going to present kind of a lot of the facts. I'm going to throw a whole bunch of statistics at you because I think that the statistics help frame the discussion, but we don't need to talk about them, and you can let them wash over you. There's nothing you have to know about the statistics. It's just a way of trying to put what's going on in some kind of picture. And if I were going to do it in pictures with graphs and stuff, you know, it might be a little more colorful and a little bit easier to see, but we'll just do it there. One of the things I wanted to say, because I was discussing, as I was talking with these two ladies, is one of the things that I've been doing with a coalition locally is a cancer resource guide, which is available online at cancerresourcesmt.org. And it came out about a year ago, and we're going to be updating it with the information, and it's available online, and if anyone ever has need to look around and see what resources there are in the area, that's one place to look. And if you know of resources that are not in there, I'd sure appreciate hearing about them. And we're doing it as sort of a pilot project for the state. So right now only our section of the state is up, but eventually we hope to spread it out. And I saw over there on the table a little thing about cancer. So it says, we know that cancer sucks and it changes your life forever. When you want to investigate new goals, we will meet you where you are, helping you to live your last year the way you want to be remembered. And that's a little statement from Hospice, and that's, we can kind of come back to that and think about that. And I'd just like to, because Michelle and I haven't really talked through how we're going to do this, I'd just like to encourage you to jump in whenever you want to, okay? As well as the rest of you, and we'll ask questions. So I have a couple of handouts, and I really believe we all have way too much paper, so you're welcome to take it or not take it and leave it if you don't want it, and then I'll reuse it later on. So cancer, the incidence of cancer, that is the cancer that they've been discovering and finding, the rates have been falling in the last 10 years. Falling.
You mean new types of places of cancer or all cancer cases?
The incidence of finding new cancer cases, the rates have been falling. Isn't that interesting?
Yeah.
Does that surprise you?
Yep. Nobody ever talks about that.
And so there's about 1.7 million new cases a year. And the rates, so just in the last couple of years, so the rate in 2009 for people to get a diagnosis of cancer was about 459 people out of 100,000. But in 2010, it was 446. So it's like dropping incrementally. And the invasive cancers that are found are a little more, what do you think, men or women? Men. A little bit, so about 503 per 100,000, and women about 405 per 1,000. Blacks much higher than whites. The lowest ethnic group that gets diagnosed with cancer is Asian Americans. So the number one, you can see on this that the new cases, the number one is prostate, followed by breast, followed by lung, followed by colorectal. So it's a little different for men. Men, it's prostate, lung, urinary, and colorectal often they say. And women, breast, lung, colorectal, and uterine. But what this doesn't show is the largest diagnosed cancer, which is, does anybody want to guess it's not in that list? Skin cancer. So skin cancer is one cancer that is dramatically on the rise, dramatically. Many of these other ones are going down. Skin cancer is on the rise. And why is that?
Global warming.
No, because we all like getting tans more than anything.
Because we all like getting tans and burned.
Which of the
So-
skin cancers are considered cancers? All of them?
So that's why they don't have this on there, because most of our cancer stats come through the hospitals when there's actual treatment and diagnosis, and skin cancers come through dermatologists, so they don't track them in the same way. And so they can't really say, and so that's when I say skin cancer, it's a large group of all the different kinds of skin cancers. And interestingly enough, it's middle-aged men who are getting the highest incidence. And it's really tied to burns, you know. So whenever a child has 5 or more burns in their lifetime, their risk dramatically increases. And we all burned as children, right? You know, now we're trying to be a lot more careful with our children, but that's why it's going up, is because we're doing. So,
I have a question. Is melanoma
Yes.
of the skin is not skin cancer then?
melanoma it's one of the skin cancers, but there's many kinds. So if they added the other kinds, it would be number one on this handout. Yes.
Is it true that melanoma is one of the least diagnosed but is the most fatal of the skin cancers?
Yes.
Is that right?
Yes. So fewer people, of all the people who get diagnosed with skin cancer, the people who get diagnosed with melanoma is a small percentage, but that's the one that people die from more often. That's what Mindy
And is
just
that
said.
sunburn related to melanoma's type of sunburn?
Yes. Skin changes,
I would
cellular
think the
cancer.
Black population is probably not as affected as the rest of us.
You know, that is true for skin cancers, but they still do have a problem. Yeah.
There's also a hereditary form of melanoma.
Yes.
Are there genetic tests for that?
Yes. And they're related to, I don't want to open up that could be a whole talk about hereditary cancers, but they're related to some other ones, like the BRCA genes that we all know about from Angelina Jolie. Those can be related to melanoma, but most often we think of breast and ovarian, male breast cancer, prostate.
I'd like to make a request. We've got this
Oh, the ice machine.
ice machine.
Yep, I'm curious.
Oh, can we just turn it off?
Yeah, I'm gonna pull the plug, but you have to help me remember to plug it back in or else.
You
it won't
legally
take that.
unplug it. We have to remember to plug it in.
Uh-huh.
But you need me to talk
Well, I was gonna
louder.
say that, but probably with the machine on.
Okay, thanks. So each year there are more new cases of skin cancer than breast, prostate, lung, and colon combined. That's how many skin cancers there are. So what's the number one risk factor for cancer, for any kind of cancer? We all do it. We all are doing it. We're all at risk because of it. Huh? Food? No.
Stress.
No. Aging.
Well, like being human, that's the one.
Yes. So that is, of course, not preventable. So all of us are going to age, and as we get older, our risk goes up. The median age of diagnosis of all cancers is about 66. But that's median because, of course, there are other cancers. And there are the ones besides skin cancer that's climbing in incidence is pancreatic cancer. Many of the other ones are on the decrease. So why are they on the decrease, do you think?
More sophisticated testing?
Testing, screenings, that's right. They catch them sometimes like in colorectal cancer before it even becomes a cancer. And or at sometimes, and that's also true of skin cancers. And what's the number 2 risk, do you think, for all kinds of cancers? Smoking. So because there's fewer people smoking now, the rates of cancer are going down. But they estimate that about 30% of all cancers are smoking related in one way or the other.
My goodness.
So that's smoking deaths, I should say. Yeah. So, but the good news is that because of catching cancers earlier and because of the treatments that are available now, the rate of survivorship is dramatically climbing. So there are lots and lots and lots and lots of survivors, whereas, going back to the topic of the top, 30 years ago that wasn't true. Often 30 years ago you got a cancer diagnosis, that meant you were going to die. That's not true anymore, and we have survivors that are 5 or more years. 64% of people who get cancer are still alive 5 years later. That was 20 years ago. It was 15%. So it's gone from 15% to 64%. That's huge.
Wow, that's amazing.
It is true, however, that people under 40 who get diagnosed with cancer have a much lower rate of survivorship. It's only about 5%.
If you get diagnosed with cancer before you're 40, you have a lower rate of survivorship.
Right.
Because it's usually more advanced.
It sells and multiply more rapidly.
It's more advanced because they don't do screenings when you're younger, and it's usually a more aggressive kind of cancer. It's on a cellular level, it's not because of the changes with aging. It's more genetic or other causes, more dramatic environmental causes, and so the younger people have a much lower rate. So even as you get older, you might get cancer more. You have a higher risk of cancer, but you also have a better risk of surviving, or a better chance of surviving it.
Does that risk of surviving beyond 5 years change dramatically, or?
Yes. So again, it was only 15% 20 years ago, and now it's about 64% of people.
And we're talking about 5 years?
Yes.
What about like 10 years?
I don't think I know that.
Something we talk about is the Medicare benefit for hospice was designed at this 20 to 30 years ago, saying if you're within 6 months of the end of your life, that's when you need the palliative care and the hospice treatment. And now suddenly people get these terminal diagnoses. They don't die in 6 months like they used to. They can live 3 to 5 years so easily, but the kind of care that we provide is really limited to those people with the 6-month standard that was set so long ago to save money. So that's one of the injustices, I think. And what we know about cancer care too, maybe you have the statistic, is that so many more people work up until, especially when they're younger, right before they pass away.
Right.
And we run into insurance companies not wanting to cover hospice care if patients can work still. And that's hard to understand because quality of life-wise,
They want to work.
they want to
important.
work. That's important.
Yeah, work
to
is
them.
one of those things that you kind of have, I just felt like I had control of that. I wanted to be at work because I had control of what happened at work, because you do feel so out of control of the situation.
And more normal, yeah.
Yeah. And, can I talk a second about when we talk about sporadic, familial, and hereditary cancers? So, and I would agree with your statement that, genetic cancers are more likely to hit younger people. So when we're looking for people that we might do genetic testing on or might read red flags, the biggest red flag is at age at diagnosis. So usually we think of age 45 or younger. If you're diagnosed with a cancer, then maybe we ought to be starting to look at your family history a little bit. So when we think about that pie of people that get cancers, we look at their sporadic cancers, there's familial cancers, and then there's the hereditary cancers. I get a lot of ladies in my office that think that, oh my gosh, my mom had breast cancer when she was 80, my risk is going to be really crazy high. And they think that they have a gene mutation or something like that. So when I talk about sporadic cancers with people, I talk about that older group. So that mom that's like 80 something at breast cancer, you know, what happens is if you think of a cell, you have to have changes in that cell is what makes cancer. So if you've got one little cell that's just kind of not functioning right because of aging and getting older and environmental exposures, we believe that it takes a couple of hits over your lifetime of hits and hits and hits of a cell to have it just like go berserk, and then it divides into 2 cells and on and turns into a cancer. So that all starts out in one cell. The familial cancers, when we talk about those are clusters of cancer in a family, and maybe it's something that science hasn't identified yet as something being hereditary, or maybe your family owns a crop dusting business and everybody's exposed to those chemicals in crop dusting, something like that. It's a cluster of cancers in a family, and we can't prove that it's not hereditary. The hereditary cancers are really only about 5 to 10% of the population, so pretty small. That population of people, you know, when you're being made as a human, you've got the egg and the sperm coming together. So if you inherit something from your mom that is a genetic mutation, and you've got the egg and the sperm coming together, all of that genetic material is in both of those things from your mom and dad. So as those cells divide to make you as a human, it's in every cell in your body, and you've got a genetic mutation too. So you've already got that one hit, because you might not have a tumor suppressor gene working appropriately or something like that. So that's just kind of the difference in sporadic, familial, and hereditary cancers, and just who we look for in the population. And age at diagnosis definitely is a red flag. And like you said, those people don't always come in for screening. I mean, if you're 30 years old and you come in with a breast mass, nobody's really going to be like, you know, oh, you probably have cancer because you're 30. Now, if you're a 60-something-year-old woman, different story. So that's where we have to start paying attention to our family histories and people knowing what's going on in their families.
Does anybody have any questions about that? Thanks, Michelle.
I don't have a question about that, but going back to your statement about age and the people 40 and younger who are diagnosed have a greater likelihood of having it be a terminal illness.
Yes.
Does that increase the like children? I mean, if you get cancer as a child, is there an even greater likelihood of not surviving, or?
It really depends on the kind of cancer and when it's found, and what kind of treatments are available for it. But the next step that really does affect children that I was going to talk about was the implications for healthcare, because 20, 30 years ago, when people didn't survive, there weren't such things as plans of care of what's going to happen after, survivorship plans, how you're going to work with your doctor, how that's going to affect your medications, your health for the rest of your life. And now children really do have a high risk of other cancers. Once they've survived one cancer, they're at a high risk of getting other cancers. And so they have to have really careful health care. And it is true that as there will be many people who will, once you get cancer, you are at higher risk of getting another cancer, either the same type or another type. And then treatment gets a little more complicated. And it won't be unusual in hospice, and I'm sure you see this, is that people may have cancer along with other diseases as well. And so it's not unusual to have people on hospice with 3 different diagnoses, right?
It is interesting though, because we've seen, I mean, just in the time that I've been in hospice and healthcare, which is like 10 years, how many parent-age people are having cancer. And like you said, they're such bad cancers. And I'm just sitting here thinking of all of them that have children and wondering, you know, are pediatricians cute? Like, you know, should we as hospice be reaching back out to pediatricians and saying, you know, here's what happened. Maybe this needs to be part of their care plan as you're raising them as a pediatrician, because they're going to have complicated grief from not having a parent. So they're going to have more stress. nutrition might not be their priority? Are they getting the exercise they need to not only address their grief but help their body recover from such a loss? And so then you take, you know, kind of that familial stress factor plus heredity. I wonder if these kids that suffered such a big loss are going to be more at risk when they get older too.
But what I'm getting from, like, is this true then? So Michelle, you were saying if the parent is 40 or younger, then likely that it would be hereditary, more likely that it'd be hereditary.
It's a red flag to do some more investigating about the family history and maybe do some genetic testing. But there's a bone cancer that kids get. It's a sarcoma, and that is a precursor to getting breast cancer when you're a little bit older.
Got you.
So paying attention to those things in family histories, even when you're the hospice nurse. I know I often get, you know, you think, like, I have an 85-year-old woman I'm working with right now that's got a terrible family history, but for her it's probably not going to be any benefit for her, but it will for her family, because when we start doing genetic testing, we like to test the person highest up on the pedigree that's actually had the cancer, because it gives us a little bit more information.
Mm-hmm.
So each offspring of your parents has a 50-50 chance. If you have a parent, I'll use myself as an example. I'm a BRCA1 positive person. So my mutation came from my mom, but she has never had cancer. My sister was the first one that was diagnosed at 30, and then she died from her cancer. So when you're talking about those kids, I mean, I think of my 3 nephews that grew up without their wonderful, precious mom. And one of them posted some stuff on Facebook recently because it was just her birthday on Monday. And it was interesting to me to see that as an adult, that he's really grieving for his mom right now. That, you know, he was 8-ish when she died. So he just made a statement in there about he really misses her really bad right now. So I kind of digressed there, but you know, those hereditary cancers can, when you're seeing those things in a family that you're working with in hospice care, just knowing that testing that person higher up is a good thing, because that person's offspring, however many kids they have, each one of those offspring has a 50-50 chance of having that mutation. So for my family, my sister was never tested. I was the first one tested at 38, and they said, well, wow, where did this come from? So they went up and tested my mom, and sure enough, she has the mutation, but she's never had cancer. And it's kind of interesting because she smoked almost all of her life and has a little bit higher alcohol content than I think is probably healthy, but
Maybe that's what killed it.
maybe that's what killed it.
Cheers.
So in my family, then, if none of us would have been tested, and my younger sister, who's negative, went to the doctor and said, oh yeah, I had 2 sisters and a cousin all had breast cancer in their 30s, and that doctor says, wow, we need to test you. Well, my younger sister that's negative, and she was the first one tested, then that doesn't give us any information about the mutation in the family, because she turned out to be the 50% that got, you know, you've got your 2 chromosomes that you get from each parent. She got my mom's good one of her chromosomes, and my sister, myself, and my brother all got the bad one.
Hmm.
So my younger sister got the good one. So if she would have been the first one to test, then we wouldn't know that there was this mutation in the family. So, and these older people that you guys are taking care of, I mean, let's say my mom went into hospice tomorrow, and she's healthy and never had cancer, but she maybe shares with you about her grief of losing her daughter at age 33 to cancer, and is, you know, talking about, those are red flags that any healthcare provider should say, you know, you ought to, let's get your family somewhere to help with that, and it might make a huge difference of preventing cancer, because those people we screen a lot more diligently than we would the general population of people.
When we talk so much about what we hear people talk about is their legacy that they're leaving, whether it's good or bad, but people struggle when they have family diseases and
Mhm.
it gets passed from a parent to a child. It's really hard for them.
It is very hard, and you
To
know,
carry
my
it
mom
out.
went through a lot of emotional distress knowing that she passed this on to 3 of her 4 children.
It's kind of empowering now that there's something to say
Mhm.
it's not for nothing. There is actually, we could gift to them knowing that, you
Mhm.
know, and some peace of mind for parents knowing.
Mhm.
It's really interesting. I never thought of it.
Is it expensive?
Um,
Genetic testing and
Genetic testing is for the most part, without getting the particulars of all the different cancers, is around $3,000 to $4,000. For the most part, it's covered by health insurance, and that's, you know, part of the reason we don't do it on everyone. We have tests now that we can just do one particular gene test, like the BRCA1 or 2. There's a 25 gene panel. We can break it down by kind of your family history. There's a 6 gene panel for breast stuff. We can test for breast, prostate, ovarian, colon, melanoma. There's a new one that's going to be coming out over the next couple of years for lung, so that'll be exciting for that
Wow.
that smoking population, and just watching them and screening them for lung nodules if they're smokers. And I know Dr. Tata does a free little screening program for smokers that he'll just come and see them, have them come see him, and he kind of evaluates them and figures out if he needs to be following them with CTs and stuff, and hopefully catching something early so that they're not dying of these terrible, terrible lung cancers. So it's $3,000 to $4,000 depending on which test we order, which panel we order. Most insurance companies cover the majority of the test, so it turns out to be affordable and good information for the patient because it can help them make treatment decisions. You know, in the beginning, you know, you might choose to have bilateral mastectomies instead of just a lumpectomy and radiation if you knew you had one of those mutations, and if you had one that was related to several other cancers. I use the BRCA one a lot because everybody knows about it because of Angelina Jolie, but that can be breast, both male and female, ovarian, prostate, melanoma, and pancreatic.
Wow. Huh.
And you wouldn't stop and think, oh wow, I have breast cancer. Maybe I should worry about, you know, pancreatic cancer, but it can matter, and it just depends on what the syndrome is. So that other one that I talked about with breast can be one of the big markers is children that have sarcomas when they're young, like 8, 10.
Is that any type of sarcoma or specific types of sarcoma in the children, or?
It's any kind of sarcoma in a child, and you know that would, when we start talking about those hereditary cancers, and that would be an unusual presentation to have a child with cancer. So you might want to just visit with a genetics professional of some sort to see what other cancers might be in the family, because you don't necessarily think about things like that. One example, I'll get off the cancer bandwagon just a little bit, is we had, I learned this in a course I took last summer, and just how unrelated things can be in your genetics that you don't necessarily think would turn into a healthcare problem. There was a man that had born with a cleft lip and cleft palate where this doesn't fuse in development, which, you know, one sporadic thing like that, no big deal. But then both of his sons were born with it. And it's just like, okay, now we need to maybe stand up and pay attention to this. So they got sent to a genetics professional who did a really full family history, and it turns out that all the men above this gentleman, the father of these 2 boys, they all had just drop-dead, healthy, vigorous, active men, like in their 40s with heart attacks, like 4 or 5 of them. And they're like, whoa, that's crazy. Well, there is actually a genetic syndrome, and that's what you get. It's like a clotting thing that causes heart issues, or you can also get the cleft lip, cleft palate thing. So now they were able to share that information with this family, and they were able to put like the gentleman and like his brothers and other younger people on blood thinners so that they wouldn't have these massive heart attacks. And you never know how a genetic syndrome is going to manifest itself. So that's a particular example of that one. And with the BRCA genes, it can be any one of those other cancers that I mentioned. So that's why it's really nice that we have other genes that we can look at too besides just the BRCA genes. And those are actual normal genes that everyone has. They're tumor suppressor genes. Everyone in this room has them. I happen to have a mutated one that doesn't work right, so that's what probably caused my cancer.
So do they know though, I had a friend that had a heart transplant and she ended up with lymphoma about within 6 months, and none of them were really surprised about it because they said it's actually a side effect.
A side effect.
From the anti-rejection medication she had to do. So decreased immune system causing that. So when they look at the sarcoma, can they really say it's the sarcoma that makes them more likely to have cancer later, or could it be whatever treatments they give them for the sarcoma that causes the second type of cancer?
Yes.
Yes.
Yes. And we know that in women that get radiation to their chests for Hodgkin's disease, those ladies have a lot higher incidence of breast cancer in their lifetime because of the radiation treatment. So the answer would be yes to.
Yeah, that kind of leads to my thought about genetic testing and are people I know it's hard to absorb a lot of information, but what it makes me think of is if you're going to go down that road of getting maybe some information back, do they have education beforehand about what might possibly be revealed? It kind of reminds me of prenatal testing and people who wouldn't ever, women who might never want to have an abortion, having prenatal testing that doesn't really apply. If somebody knew what their values were up front to the choices that they might make down the road.
And if you're one of my patients, yes, you get that conversation because not everybody wants to know. And not everybody, somebody might want to know if they have like the BRCA mutations because those are the most common ones of the hereditary breast ones. But they might not want to know if they have one of the more unusual ones because that one causes a diffuse gastric cancer. So are you going to go get your stomach removed? I don't know. It's kind of, you could, but it'd be kind of difficult to live like that. And it's not, that particular one isn't one that we can always see really well on endoscopy. So this is why I really encourage people to talk to you hear me keep saying genetics professional. So a lot of people just refer to genetic counselors, but there's a lot of us nurses out there with special training and special education, and where the nursing world is starting to rise up, step up, and be able to do genetic information testing and education to patients. So that's why, I always think, I had a doctor say to me, I don't know why you spend 45 minutes to an hour talking to this patient about all of this, because if I think they need it, just like a tumor marker, I'm just going to order it. And I'm like, ooh. Because there's a lot to think about. They might not want to know. My mom didn't want me to tell the rest of my family, and as a nurse, that was really hard for me. And I said, well, I'm sorry. I'm going to tell them, and I'll give a copy of my results so they can be tested if they choose to. But I never would push anybody to be tested if they don't want to. And when how much do you want to know about your genetics? If UW has that 40 gene panel. Do you want to know about that? And sometimes we don't get a black and white answer. We get an answer of something called a variant of uncertain significance. Well, what do we do with that? Now, how do we manage your health care? Do we treat you like you're on the high end of being positive, or do we just kind of let you be out there? And that's a conversation that you have with the patient that you're testing, and where are they? Some people, I'm the kind of person, I want all the information I can get, and some people, someone that's a worrier, and they're just like sitting around, doing breast exams every day on themselves or checking their skin for melanoma. I mean, those types of people, maybe that's too much information for them. So I hope that people are getting that information. I can guarantee you if they're one of my patients I'm talking to, they are. And most genetic counselors and other genetic professionals would do that too, I would hope.
I mean, I think just being in hospice, because we're around diagnoses going bad all the time. Like I get a headache and I'm like, brain tumor. Like, so if I knew that I had some diagnosis, I would think every time I had a stomach ache, I'd be like, oh, I'm probably gonna die. I mean, I know that that's my personality, so I think if it were something like that, I might say like, I don't really want to know. Like because it would change the way I thought about my life from day to day.
But on the flip side, if it was everybody had breast cancer and I was positive, going back to Angelina Jolie, like
Mhm.
how I would give up those parts in a heartbeat if it meant I got to be around for my kids.
Mhm.
Even if, but without the
But
knowledge, how
gastric?
do you do, yeah,
You know,
power, but what?
but gastric.
Yeah, gastric, what are you gonna do
Yeah.
with that?
Yeah.
Like, or your brain?
Right.
What are you gonna do with your brain?
I
Like,
probably could do
use
it
it?
on my brain.
Like, pick which part you take?
Yeah, like the scarecrow.
That'd be nice, yeah, thanks.
Yeah, that is an interesting.
So it's an interesting thing that where we're at in history is we can look back and see how much more we know now than we knew 30 years ago, and get a glimmer of what we might know in 10 years or 15 or 20 years. You know, it could be a very different discussion. There's so much research going on with genetics and treatment that could change this, that where it might really make sense to know, because there could be something you could do about it, you know, for other things
And
besides
targeting
breast.
targeted therapies to that particular person's
Yes.
tumor. I mean, we already have those tests out that we can do. Oncotype testing is one of the things that we have, and it's we actually test the makeup of your tumor to see what makes your tumor tick. And we have things like estrogen is one of the things we look at, and HER2. We have therapies for those things now. So if you're a HER2 positive woman, you're going to get Herceptin. There's another new drug, Perjeta. If you're an estrogen receptor positive woman, you're going to get tamoxifen or Arimidex or something like that. So we've got those great targeted therapies that target the actual tumor cells instead of just destroying everything, like adriamycin and Cytoxan, which are common chemo drugs for breast cancer. You know, those are heart toxic, and they can be bad for your bones and all those things. So I
do you
think we're going to see a lot of big changes. I mean, we already are in these targeted therapies based on what the cancer, you know. Hopefully we'll have to put hospice out of business and people won't.
Or population.
Well, yes, but this reminds me of this question that comes up every now and then in these conversations. And that, well, we've even had a doctor say if he had his choice, dying of cancer would be preferable to him because it would give him time to make his preparations. And, well, contrasting that with Alzheimer's, for instance. Yeah. And because we're living longer, these questions come up. Well, I'm going to die now. Which would I rather die of?
And you know, my sister that died of her breast cancer when she was 33, I mean, I was just like, I just don't even know how she could fathom thinking about leaving her kids. That was the big thing for us, and we talked a lot about that. And she said, you know, I feel fortunate to know that I'm dying, because just like you said, she could plan it. She planned what happened at her funeral. She took the time to, she wrote little memory books for each of her kids, and the one I was talking about that posted on Facebook, he had been reading the book that his mom left him, and she talked to him in that book, and I just so admired her for being able to think about the other people that she was leaving behind and how those things would help. She recorded herself reading them their favorite books. So like her little grandson now, he has those things to remember her by, and I can tell that my brother-in-law was so wonderful about continuing to talk about her, because one of the girl that married this one that posted on Facebook was here this last year with me by herself, and she was so curious about my sister, and I would talk about things, and she knew so much about her just because of the things that she had left behind for the boys. You know, the youngest one was probably only about 4 when she died, and the only thing he probably remembers is his mom being sick. So being, you know, I think I'd say I want to know what kind of cancer. I don't know. I don't want a guy die from lung cancer. Doesn't sound very, very pleasant. And you know, I'm not saying that her death was really pleasant. I mean, she was having seizures and things at the end that were really scary to her family. But hospice was so great to be in there and help us all.
And that's changed too. Well, let's move on with the statistics a little bit. This is a really interesting discussion, but I just wanted to ask, what do you think about Montana compared to the rest of the country? Do you think in Montana, we're talking about incidence, not death, do we have a higher or lower incidence than
We have a lot of sun in middle-aged men not working compared to maybe New York, where everybody works inside, so that makes me kind of think of...
We're talking all cancers?
Mm-hmm.
I would say we're lower.
Do you?
We have a
With
lot
all
of
the
heavy
chemicals
metals.
and
Lifestyle.
Western
Well,
medicine.
exercise.
Maybe.
Okay, now I'm just I want to implant that memory, yeah.
We had one of the first Superfund sites here.
Yeah.
Sure, sure. Well, from 2006 to 2010, men were lower, women were higher. Isn't that interesting? So there's a couple of different things that happen in Montana that are unique. Women have a higher incidence of breast, lung and urinary, and bladder. So lung in particular is of course related to smoking. Women in Montana have a higher rate of smoking than some other places in the country, so that explains that. That can also explain part of the breast because it does contribute to that.
You said bladder too.
Mm-hmm.
So smokers more often have bladder cancer because
Yeah.
that just sits in the bladder.
Yep, yep, so that's a lot. Men, the prostate is a little bit higher, just a little bit, but lung is considerably lower, which is very interesting to me, than some other parts of the country.
Not here.
Yeah, yeah. But this is what's interesting, and where I think what you said about the lifestyle comes into factor, is that one thing that skews that is our high population of American Indians, because the American Indians have a much higher rate of both incidence and death of cancer. And want to throw out ideas of why that might be?
We haven't had all of the years of accustomation to all of the awful things we do to our bodies.
And they typically don't have health care, so they don't go in for screenings.
In the healthcare they have, they don't necessarily trust. Higher rates, you're right. Their lifestyle, alcohol, smoking, obesity all tends to be higher. Diabetes, yes. So yeah.
women, it's breast, lung, bladder, urinary. Is there one more that was higher?
Breast, lung, urinary, bladder. Yeah. And so both women and men in Montana are one area that's really lower than the rest of the country is non-Hodgkin lymphoma.
Can you talk, what's the difference between, we hear about non-Hodgkin lymphoma all the time. Is there like Hodgkin's lymphoma, and why?
There is, and I am not a lymphoma expert, so
I'm not going to be able to tell you that.
I was just wondering if it's more environmental versus familiar hereditary.
I would say it's probably not, it's not one of the high hereditary cancers. Unless you have like a huge family history of stuff.
Okay, so now I'm going to switch from talking about cancer incidence, because again I want to emphasize survivorship is high. Just because you get cancer does not mean you're going to die from cancer now. But let's talk now about dying from cancer. So cancer is number 2 in the country for your mortality risk. Number 1 being heart disease. In Montana, they're very close. Interestingly enough, and that might have to do with our healthy lifestyle and being outdoors more, but cancer is very close in Montana to being number 1. In some years it may even pass it up here, which is very interesting. That's considerably different than some parts of the country where heart disease is way higher than cancer. So again, there has been a decline in deaths as well as incidence. So a 20% decline in cancer deaths from 1991 to 2010, and that's rates, of course, not number. 20% decline. So we've already talked about why. It's better screening, better treatment, better catching it earlier, and a drop in the rate of smoking. Black men still have the highest rates, and American Asian the least for death as well.
Did you say 20% in the last 20 years?
Yes. And it's been steady, so it's been about 1% a year. It's going down. But they think that's going to turn around and change because, what do you think?
I think that it's going to change as in it's going to go up.
It's going to go up. The rates are going to go up. What's the number 1 risk?
For the baby boomers.
Aging. So as our aging population increases, of course the rates of cancer are going to increase, just like with Alzheimer's, other things, huh? The silver tsunami, that's right, that's right. So even though it's been going down, they do expect that that'll turn around. And because, it's in their 60s, and that's where all the baby boomers are starting to hit, that we could see a change in that. So breast cancer has dramatically dropped, 35% drop in breast cancer deaths since 1990. But even though the number one kind of cancer is prostate breast, the number one kind of cancer death is from lung cancer. Because breast cancer is, of course, much more treatable in today's world. May not be in the future, but right now lung cancer is harder to detect and harder to treat. And so that's the number one kind of death. So in men, the deaths are lung, prostate, colorectal, pancreas. Women, lung, breast, colorectal, pancreas.
Why do you think the pancreatic rates are going up?
Why do you think?
I think it's exposure to stuff, toxins myself.
Yes, I think so.
Preservatives
And alcohol.
in food, you mean, and all that kind of stuff.
Products we use, things in our
Environmental
food,
toxins.
environmental toxins,
Yeah.
our diets.
Uh-huh. And it is
What's the
related to
pancreas do again? Help me
alcoholism.
with this. I mean, everything does something. Pancreas's main role is hormone production.
Pancreas has a lot to do with keeping your blood sugars under control and all that kind of good stuff. It's very important.
So it's probably related to the increase in diabetes in the country too.
Diabetes and sugar.
Mhm.
For sure.
More sugar.
Right.
Sugar is the devil.
The devil.
I've been reading Dr. Mark Hyman's Blood Sugar Solution book, and there's a movie. Has anybody seen Fed Up yet?
Yes.
Did you see it? Is it awesome?
Yeah.
I gotta go see it.
It's like
a
blows
movie
your
about-
eyeballs, and I love sugar. Like
I know,
I didn't
I
eat
love
sugar.
sugar. I've been
Then I
trying.
forgot.
I've been trying to like be good at it.
Watch
It's
it
so hard.
every
It's
month.
in.
That's
It's in
every
everything.
month.
It's in everything. It's unbelievable. I picked up like a
Corn
low,
syrup.
you look
Bread.
at low calorie stuff has lots of sugar, and I picked up like Newman salad dressing had like 4 grams of sugar in one serving.
Yeah.
Hamburgers at McDonald's have sugar in them.
Oh, McDonald's, that's, oh.
Isn't that amazing?
Okay, so I just want to go back and challenge that idea that the silver tsunami is going to increase the rate of people that die of cancer. I mean, there'll be more people dying, but why would that increase the rate of them dying of cancer? That doesn't make any sense.
It's actually that increases the rate of incidence of cancer.
Incidence.
And- right. And so, and the kind of the follow of that would be the rate of dying of cancer will go up some
We're
too.
the same population still, but since some are older,
More of
a
us.
higher percentage of us are going to be diagnosed.
They also think that it has to do with things like because of how we've lived as baby boomers, with everything from our sunburns when we were young to the rate of drinking and sugars and the environmental toxins that are around.
Smoking. Did you guys smoke when you were in high school?
I didn't.
So it seems like it was my grandparents' generation that smoked before there was even a smoking age to smoke. And that
Right.
the surgeons were having cigarettes while they were doing surgery because, feels like a long time ago now.
All the nurses in the report room smoked except for myself. This was like 30, 40 years ago.
Yes.
Inside the hospital.
Yes,
yeah.
in the
I
report.
had a nurse,
Blows my mind.
and she said when she worked in the ER at community, they would be smoking until a patient came in. They would take the cigarette and the ashtray and put it in the drawer and close it. And there'd be like smoke still coming out. And have the conversation. Like then take it out, smoke again. I was like,
Patients would be
Yes.
smoking.
What?
It was crazy.
Yeah.
it's really changed so much.
It has changed.
quickly.
So that's going to be a great advantage down the road, but those of us who grew up with that are going to suffer the consequences of it.
That's like a hand, right?
Yeah.
I mean, I don't want to tattle on my mom, but she smoked the whole time she was pregnant with me because she wanted a low birth weight baby because she was young and scared. I mean, it was like, oh, a smaller kid. I was literally the shortest one.
I still see parents smoking cigarettes in their car.
I know, that drives me
With
crazy.
their kids.
The windows rolled up.
Like, it just drives me crazy. What do you do?
I'm just waiting for the microwave study to come out. I don't know.
I don't know. I don't have any statistics on that. Okay, so once again, 30% of all cancer deaths are attributed to smoking. It is the leading cause of preventable death worldwide. Smoking is. So interesting enough, as people get older, to be over 100, they don't usually die of cancer.
Because they live to 100 somehow.
Exactly. Somehow the risk seems to be between 60 and 90, you know, and if you've made it, if your cells are strong enough to make it that long, you're not going to die of cancer.
That's a good goal to set.
That is a good goal, isn't that? So what do you see in hospice when people are 100? What do they usually die of?
General body badness.
Frailty, pneumonia, infections.
Tired bodies.
Yep, true.
Do you have any statistics that show like cancer deaths as far as smokers that quit smoking for like a period of time? What their death rate is versus someone that just continues to smoke throughout their lifetime?
I do know that the risk, you know, it's for every period of time that you go, your risk goes down for cancer. It still stays as high, a little bit higher than people who never smoked, but it does go down the longer you can go without smoking.
Right, I saw a study that said if you had stopped smoking before you're 30, there was a huge incidence of like you not getting cancer. Like it was much better than anyone else who smoked past that. But I don't know who studied it, so it could be crazy wrong.
Yeah. Okay, Montana. How do you think Montana deaths from cancer vary from the United States? Higher or lower?
Like percentage of Montanans that die from cancer versus the rest of the United
Yes.
States?
I say higher.
So
You're not such a pessimist.
overall, it's lower. Except, again, female lung, because females tend to smoke a little, at a higher rate in Montana, and male prostate.
I would have
So,
thought
isn't
there
that
would have been
interesting?
access to care issues in a lot of the rural
You would
areas.
think.
That's what I was
You would think. Okay, so let's talk about hospitals. So the number of people who were admitted to hospitals from 2000 to 2010 increased about 11%, but the number of people who died in the hospitals actually decreased by 8%. Mainly women. Men was about the same. And the number of people who died in the hospital with cancer decreased 46% in that 10 years from 2000 to 2010. So people with cancer, the good news is that they're finding ways of dying more with hospice than the other. So there is an interesting study that I read research a lot, and so one study just came out that said this is sad, and I'd like to see what you hospice people think about this. There was a study that older cancer patients have significantly more underaddressed pain than people under 50. That somehow the people under 50 are given more palliative help than older people. Do you think that's true? Have you seen that?
I don't know about accessibility to that help, but I think that acceptance of that help is probably lower for that generation. I mean, that's my experience anyway, just hearing they're afraid of taking narcotics because they'll be addicted. They would rather not talk about their pain because they're worried about having to leave their home and losing their independence. I mean, that's sort of the theme that we see, I think.
That's
is
very interesting.
They probably do have higher rates of pain, but it's not because it's not offered to them. It's not because that palliative care isn't available. It's because they are a lot less willing to access it or utilize it.
Or have been conditioned to pain. I mean, these generations above us, despite Eric Gentry at the trauma conference says we're living in the safest world we've ever lived in, yet we're more fearful ever. And I think that generation that actually experienced those things have been conditioned to really painful experiences, and that buck up and hold it and carry it with you. You know, that they've just been conditioned that they're old, they're supposed to be in pain, and this is how it is, and they're either not as likely to ask for help, but this is just who they are. Whereas this younger generation, our traumatic experiences are more secondhand in nature. Like, we don't actually have as many of our family members leaving for war and then coming back and going through that. And we've become better advocates. I feel like that age of 50 and below was like, I don't let you put faulty parts in my car. I'm gonna make sure you're putting the right thing in my body before I just sign up for it and ask why. And I don't think that older generation has been groomed to challenge their physicians, or if the physician says this is what I need, or I shouldn't have pain there, then I must not have pain there and it must be in my head. So I think that that's a big...
But that's such an interesting thing for me to hear. You know, when we interview patients in the home and we're talking to them about pain management and what they have access to even in their home. Like they probably have prescriptions that would be helpful. And they say, I don't want to take that. I don't want to be addicted to it. And I think, well, that's a really interesting thing because you're on hospice and like what's going to happen? Like what's the worst thing if you did become addicted?
Yeah.
Which isn't going to be the case, but like, how would that be a negative at this point? It's so interesting, but that's really ingrained in their personality.
You're supposed to have pain. I mean, this is who... It's suffering is a normal part of life, and it's not that we can't suffer through it, and they become married to it in a weird way.
Right. I mean, it is part of life. People are choosing to have natural childbirths, and that's normal and natural, and they don't
And
have
that's come and gone,
right.
too.
And that's sort of coming back in the swing of things. And Georgia did that great talk talking about suffering at end of life, and like, yeah, a certain amount of suffering should be expected. You know, it is a transition, and it is hard.
The thing is, though, in order to have this data, in order to have this number, it implies that those over that age were reporting pain.
Right.
Mm-hmm.
So
somebody had to ask the question, right?
Mm-hmm. We asked.
and they got a straight answer.
Right.
Mm-hmm. Well, and I don't think that generation of people either just makes their wishes known or to their family. I mean, I see people all the time that come in that have nothing in place.
Mm-hmm.
And that's just what they did, and their family buried them, and that was it.
Oh, yeah. My grandpa was in the hospital here, and I would go in and like, hey, Grandpa, how are you doing? And he's like, you see that pain chart on the wall? Like a 9 or a 10, like it's unbearable. I can't even drink my coffee. And then the doctor came in, and I said, I think he needs something for pain because he was like, no, I'm fine. I was like, what just happened? I mean, so he was willing to report it to some people and not willing to report it to other people within like the same minutes. It wasn't like later, and then he felt better. Like, So interesting.
So
He
it's
wants to be a
really-
good patient, which we see. Wants to be a good reporter, no matter what, because he wants the doctor to befriend him and be happy with what he's saying. And we see that a lot too.
They don't
Makes
have
them feel guilty too sometimes.
Right, like I'm failing because I'm in
I did something.
Mm-hmm.
So a conclusion might be that we really need to continue to ask and not make assumptions
Mm-hmm.
Well, and that
about
not all
people's pain.
And the other thing we talk about is not all pain is really physical.
Uh-huh.
And that body talk idea, and then
Yeah.
it's really interesting to look at where people are getting cancers or
Yeah.
other chronic conditions and
Yeah.
women parts. I mean, that's like kind of a far reach out there, but the female parts and getting cancer in those places, I don't know. There's
But we used to talk to
Interesting
people
part.
who, you know, when I worked in a rheumatology practice, there was a lot of pain, and there was the same word about addiction, and it was really, the physician that I worked with was so good about explaining that as, you know, like you wouldn't use a fire extinguisher just for fun, but when there's a fire, it's appropriate, right? But it could be misused, sure. This pain medicine's the same way. When you have a fire, like pain medicine works, gone, but if you just use it for fun, yeah, addiction can happen. Like it makes sense. And that was a nice sort of correlation for people to understand. The purpose is to get rid of this. Once that's gone, we can see about taking it away. Not that it would be permanent or addictive in that way. I think it's how you frame it up, or if you have physicians willing to have that conversation.
That's helpful way to look at it, yeah. Okay, so we've been talking about hospice, so let's jump into the hospice statistics.
Thank you.
So in the 1970s, most hospice patients were cancer patients.
Mm-hmm.
That's really changed. So in 2011, 37.7% of hospice patients throughout the country were cancer patients. In 2012, it even went down a little bit further to 36.9%. Do you think that's true here in Missoula too?
or lower.
Even lower than that.
Well, incidences, I think people who come in hospice that have cancer die much quicker than people who are dying from general body badness.
Yes.
Because they can't access it if they're doing any type of treatment, radiation or pill-wise, and the idea of palliating cancer growing, palliating pain and those symptoms versus keeping the cancer from growing, that's a really interesting discussion, and we kind of get left out of it because of the inability to access the benefits because of insurance and so I think that's why everyone is talking about palliative care so much, because it's a safe way to address the symptoms and the side effects of going through these treatments. It's just the irony is that we're so good at doing palliative care as a hospice team that to not have us in those discussions because we're seen as like the last step and the people that are going to be there when you die, it just doesn't serve upstream because they feel like it's a failure part. Dr. Specker actually had told me about a study from, or a statement from, who's like the oncology board of all the oncologist physicians saying, if anyone has a stage 4 diagnosis, meaning it's already spread to some part of your body, like the first initial consult, physicians should be telling patients hospice will be part of your care plan, not today. And it just plants the seed of the expectation of, we are going to have to embrace that being a part of your life at some point, but not today. And so then it isn't that uncomfortable, like, oh, he said hospice today, and we've been dreading them finally saying those words, and he did it, so it's this big failure. It's like taking that off the table. But Dr. Speckett says, we know this is true, and we all read it, and none of us are willing to go there. It's just not our nature. And he's so sincere about it, and he gets it, but he said it's just too hard.
Well, and I think too, Dr. Nichols always says, if you talk about that, then you give up make them give up all their fight and their hope for, what the time they still have. And so it's really hard to just kind of say, oh, hospice, because everybody thinks of hospice as that's the end.
The imminent dying part.
Imminent, immediate dying. And it's so hard when those patients get diagnosed with these bad, like pancreatic cancer. I mean, those people don't live very long. And just, you get that diagnosis. I had a lady this week that she was a breast cancer patient. She went in for abdominal pain, and we all thought we were taking her gallbladder out, and they took a biopsy, and it's a brand new. She's 2 new primary cancers, liver and bile duct cancers, and her prognosis is bad. So she thought she was coming in to get her gallbladder out last week, and now this week she's being told she's not going to live very long. And so how do you plan for what you want at the end of life if you don't start doing it when you're healthy? And it's not something that people normally think about.
Well, and that's why we talk so much about, like, everybody wants to focus on the diagnosis and the treatment for the diagnoses, and we're trying to pull everybody away from focusing on those things and saying, what makes your 24 hours a day feel good and most important to you? Is it being with your family? And then how do we make that the priority, no matter how much time you have left? If it's 7 years or 2 months, that time with your family has to be the best time for you. Or are you willing to give up a little bit of that time if it means you get a little more time, And it's the discussion focuses from just the diagnosis to your whole entire life. And it's oncologists, I've read things that say oncologists are scientists, and they're very focused on tumors and chemos, and they're very good at that, and I'm so grateful for that because they're so good at it. But how do you incorporate remembering that it's not only the tumor and the chemo, it's what that tumor and chemo buys you time to do, and can you even do it? And
not only for the patient, but their friends and family too. I don't think we think about the caregivers, and that's a really hard place to be in.
Because it's their death of their loved one or their last time with them too. Yeah. No wonder people don't want to come talk about this stuff. It's not feeling,
But I think that it's nice to talk about it before you're diagnosed with something, so that you at least have that pillow to think I've already thought through this somewhat.
Yes.
How would I want this to be for me?
Exactly.
Yeah, I think it's nice.
So that's one change that's dramatically changed over the last number of years is advanced directives, right? Is now whenever a person goes into the hospital, they're asked about their advanced directives, and sometimes other times as well. That doesn't mean that everybody has advanced directives, but it is being talked about a whole lot more than it used to be. And that's one really positive change that's happened over the last years, and there's still challenges of doing more. Yeah. So you talked about length of stay. The cancer, the average length of stay in hospice is between 35 and 62 days. And that's a slight increase over what it was back in 1998.
Cancer length of stay is 35 to 60. I would have never said that or guessed that or anything. I would have guessed 2 to 6 days. Honestly.
I don't
Don't you
think that
think
statistic
So-
incorporates Montana.
So that's not true here.
Yeah, no, that is not true here.
The majority of our short stays, which I would consider to be 3 weeks or less, are cancer diagnoses. I would
Interesting.
consider.
Yeah, oh, easily. Yeah.
And
So-
are they cancer diagnoses of like some of the really bad stuff like pancreatic, or are they just waiting till like
Yes,
the
they're
very
either,
end, like a breast?
they're either
breast
people who
met?
have fought it so hard to the very point where they can't fight it anymore, or the last chemo kills them, or they're people who got such a big diagnosis that the doctors say,
Can't
let's
do
not
it."
even mess with it for your last 2 weeks of life. Go home and make it what you can. I feel like those are the two.
Right, I mean, that second one, I don't think, just in my experience, is much, that's not as likely to happen as it is someone's been treating. You know, they throw up in the parking lot, the physician calls us, they refer to hospice, they die the next day. Happens much more than I think it should.
Right. So that's part of a change because of the treatment options that are available now. And so as we've talked about, the oncologists think that they just want to continue to try to fight, and that sometimes it's true. They try one kind of treatment, it may not work, they try another one, and it may work. And that is one reason we have such high survivors, is because there are a lot of different ones. But when there's a whole series and none of them are working at some point, it's called salvage regimens, and there's generally, it gets to be a low response rate, and there's no change in life expectancy at that point. And that's where the conversations don't always happen between the doctor and the patient, and encouraging them to go to hospice. And that's what we would like to see change in the culture. And there's a really interesting article that I'll pass around that I made copies of that you could take or not take, but about that situation that Deborah Hayes from American Cancer Society just emailed out. And it talks about how the oncologist was really in a good, with their good heart, really said that they just didn't want to feel like they were letting the person down. That they let's see, what's the word?
She doesn't want me to think of giving up.
That I'm abandoning her, right? And so it's not that that it's done really trying to ignore the person's needs. I think I really want to give them that credit, but the reality is it's not always a service. And this article is a really nice, goes through the story and talks about how palliative. A palliative professional really made a difference in that, and was able to be they were able to say things that the oncologist wasn't, and they were able to work with the oncologist to finally say, okay, let's make plans and move on. It's a really nice example of that, but it doesn't always happen, and
Sometimes the oncologists think that they have had that conversation. I mean, I would say a majority of them that we talk to, they say, but I did tell them if they do this, they're not going to want to be alive, and they choose it anyway. And so those conversations look different from every side. I mean, it's multifaceted, and it's not the oncologists always that are saying, like, I want to try it, I don't care. It's the patient that says, I don't really care what my quality of life is, I want to live longer. So I think that that's a hard rap that they sort of get always, to say, like, I'm the one doing it.
And then there's pre-programmed to think as soon as he says something isn't working, or I can't do this anymore, then that is my death sentence. Because consider the conversation, and we watch this movie all the time with our volunteers, especially. The physician says, I told my dear friend, it's time for us to change our goals and go to hospice now. And then the wife he overhears the wife telling a story that the doctor said there was nothing more he could do for us. And he spun his head around and said, no, that's not at all what I said. I said, we have to change our goals. But she heard, there's no more hope. And he's just like, so no matter how we say it, sometimes they're not going to hear it. But as a mom, if I did have cancer, I would probably want that oncologist to say everything earthly possible to get me whatever more time, even if it meant I suffered a little more. Like, as much as I am pro-hospice and pro-good death, I'm also so pro-life that my life, that I am going to want to cling to all the right hope. So it's just, it's so hard, I think, until you're there. You cannot ever judge or generalize any situation. But it's just encouraging to hear, because sometimes we feel like we're fighting this fight of getting back to the whole person and not making it just a science.
Yes.
But to hear some data really actually is very encouraging. Do you think it's encouraging?
I mean, I think it's just nice that people are aware. I mean, it's important to keep our tabs on that. And for physicians to see those statistics and for patients to see those statistics, I think that's big. Mm-hmm.
You know, I think that's where nurse navigators and social workers come in that because, I mean, when my patients get diagnosed with cancer, I get this big notebook ready for them, and one of the things I put in there is advanced directives, and you know, you have to be real careful with that, and because they think, oh my gosh, I've got cancer, she thinks I'm dying. So I explained to them that, you know, if the lady's coming in having a baby, get asked this question, and I'm just giving you this because all these appointments you're going to go to, they're going to ask you if you have an advanced directive, and this is just some information for you, you know. Yeah, and I think that those are kind of people that we can look at to help get that information and get people thinking about it. And people, I mean, it's confusing. I listen to Deb Ribby, our social worker, sometimes talk about your advanced directive, your living will, your pulse, your this, your that. And I'm
DNR,
like,
different hospitalized.
yeah, and it's like, what?
Just what you want during that period of time is to do more paperwork. But, yeah.
And it's confusing, and I don't think people know where to go to even get help
Right.
to do it either.
It's true. It's true.
So do you two office together, both at the health department? Are you both at that? You're at the
I'm at the health department.
I'm at community.
and you're at community?
Mhm.
I just want to know the list of like 5 cancers that if you get, you are so shit out of luck, you shouldn't even go see an oncologist. Like, that's what I want to know. And there have to be some, right? 'Cause some are treatable, some are not treatable. Like, which ones are the not treatable? So I can just cut my cat and go like, no, I'm gonna be fine.
Yeah, sort of treatable for a little while. It just depends.
I think, right, it depends on
Really
what
says,
stage they're
what's
at.
your-
Yeah,
what
it has
you're
more to
at,
do with,
where you're at and what your
I don't know,
quality
lung
of life
cancer
is.
doesn't look that good to me.
Lung cancer's not so great, and
Yeah.
neither is pancreatic.
right. And
Although I've heard
melanoma.
of pancreatic people living now 2 or 3 years, which when I started 10 years ago, it was like pancreatic cancer, you're going to be dead in 6 months.
That's right.
Despite the big fancy surgery you have to go 3 states over for. That's your sentence. And now I meet people that it's like, oh, I had pancreatic cancer 3 years ago, and it's like, wow.
Wow,
I didn't know
that's
people
right.
could have
Yes.
pancreatic cancer 3
And
years
things
ago.
are changing. Things
Do
are changing.
economics affect people who don't have health insurance, who have a cancer that can be a little bit treatable? Do they decide they don't want to affect their family?
Absolutely, absolutely. Definitely, you know, medical care is just really expensive and affects people, and all the time people make choices. Even now, when more and more people are getting health insurance, some people have such a high deductible. I was just in a meeting today with a cancer screening program, and they were saying that the cancer screening program is going to start covering people who, once they've been diagnosed, even if they have health insurance, but they have such high deductibles that they can't do the treatment. But they have to know that, because a lot of people do make that choice that just say, I can't afford it. And that has definitely been true in the past, and even with people getting more health insurance, it's true, absolutely. But let's talk about palliative care. So that is another huge change that's happened over the years, because palliative care started with hospice, right? And it used to be equivalent to end-of-life care, and that's no longer true anymore. So that's really a huge change that's happened. It's just one of the ways that I think that hospice has sort of done some really groundbreaking work in healthcare. You know, they've really brought to healthcare the idea of palliative care, team management. They've brought, you know, with kind of the wraparound care and the patient-centered medical homes now, and how all of that is really cost-effective and better for the patient all the way around. And that's another change that's happened. That's palliative care starts much sooner. It doesn't start once you go into hospice. When you get cancer, it's earlier. but it's still definitely a huge part. And I wanted to ask, do you think palliative care has improved in the last 20 years in hospice?
So are you saying can hospice like manage symptoms better in the last 20 years?
Yes.
Yeah. I would say yeah, definitely.
Do you agree?
Well, I don't have that much experience. I've been in hospice for 7 years now.
In
But
7 years?
I would just guess that that's true.
In 7 years, have you seen any change in that?
I think so. But I have a feeling you have a different perspective.
No,
was a
I would
hospice
hope-
nurse
I
in
would hope that was true.
1981, with the beginnings of hospice here in Missoula in 1981.
Uh-huh.
So I know what we were doing then, and I know some of what's going on now just from my association with nurses. So we did amazing pain control at that time. There was, what should I say, it was very free flowing. We were all volunteers for the most part. I was actually a paid staff, but the doctors just gave us the morphine and we went out and
So mainly morphine.
yes,
Mhm.
yes, yeah. And that was, and it was really nice to be able to talk to people who were, when you first met them and their biggest fear was, am I going to just really be in agony? And I could say, we have morphine and we have it IV. And you just get that and you just feel so comfortable and so floaty. If you're no longer eating or drinking, you'll sleep away. It's just, it wasn't a huge discussion about is that right or is that wrong. It was comfort, yeah. So, yeah. It
I
worked-
think we have
it
a
worked
bigger
well.
toolbox, but those are still our
Right,
main.
right. I know
They're still
you're
our
using a
go-to.
lot more fentanyl and Versed and more.
But a lot stayed the same, I think.
You want to be able to tell someone that they don't have to die in pain.
Right, people don't want to be in pain, they don't want to be alone. I mean, I feel like those are the two most common fears for dying. Like, I don't want to be in pain, I don't want to be alone.
I worked for Specker for a couple of years too, and he would sometimes bring somebody out and say, well, Jackie's the morphine queen or something, he's just his flip personality. And I'd say, I've never had it, I said, but I know what morphine can do to help.
Yeah, that's a pretty big honor. Like, let me be the morphine queen.
Yeah.
I
I know,
I'll take it.
I know, yeah.
I think that since I've worked with hospice, we probably had about 1,000 patients. And I can't even think of 3 of them, maybe 2 or 3 where we were really struggling and working at how are we going to be able to control this person's pain. It was an ongoing, it was a lot of work to figure out how to do it. But I
Yes.
can't think of more than 2 or 3 cases like that.
That's wonderful, isn't it?
It is.
Mhm.
Yeah.
It's really nice to be able to tell people with assurance, we really can control your pain.
You'll
Or-
never forget the ones you can't control.
Mhm.
And in a hospital setting, the bone must have been, a young person, 30s, must have been stabbing her, broken and stabbing her in the ribs or something. Fortunately, it was just a few days, but we had the morphine, we had everything just sky high. Lethal doses going, and she was,
So,
it's just, you'll never forget those. You're saying 2 or 3.
it is, there's a handful, but I can think of most of them off the top of my head. And I think that generally it's because we overlook the fact that your organs can't process some of those medications when certain people have a resistance to that. So it wouldn't matter how much you give them, it never gets to the right place.
Didn't seem to.
Yeah, it's hard.
Do you guys feel like people are more accepting of more complementary type therapies than just medications? Or is there still kind of a little, like I hear people say, about hospice, if you mention it, sometimes it's like, I don't, like, or it's, I don't want somebody just sitting at my bed playing the harp while I die.
Yep, that is definitely a stereotype that harp players get.
Yeah.
The music thanatology gets a bad rap.
I know.
Yeah,
And
there are a
I'm like,
lot.
no, no, no,
We've
no.
had massage therapists now for
Yeah.
years, and there are a lot of people that are really happy about having massage therapists
Yes.
come to
About like acupuncture
Therapy.
and guided visualization and stuff like that?
I mean, I think that those things are, we use them a lot more than we ever have, but we don't usually tell people that that's what's happening. Because if I tell somebody like, I'm gonna bring someone in for a little guided hypnotherapy, people are like, yeah, no. But if Mary goes in and we say this is relaxation and this will help control your pain, then yes.
Yes.
So it's how we frame it up, but we use those things so much more because we see the bedside satisfaction and that it does bring relief, that we're really eager to help people have that.
But again, I think the greatest benefit from those things come from established relationships that we haven't met them 2 days before they're dying.
Right. They have to trust that when you bring in the heart, you're not just hoping that they get that.
No, and today I told someone who did understand the power of touch. You know, after a massage, I feel so amazing and relaxed, and my body's just calm. And then she had come in and said, "The heart, don't bring the heart to me. It's awful." And I said, you know, for some people, a session with Lawrence and his music, they can leave a session feeling like they just had one of those intense massages without having to be touched physically. And she just like got this skeptic look, but I could see the shift in her thought, like, well, but I really like massage, so maybe that could work for somebody. But I think it is so much of how you frame it and the education. I just think the education and meeting it when you're not in crisis is really important, because anytime someone's in a crisis, they're going to be stuck in what they think, and there will be very little to no flexibility until that crisis is done. Yeah.
That's pretty common. The cool thing though, I mean, I think that we're learning because of technology. We can learn what other people are doing around the world and incorporate those on our own. So we have a lot of patients with dementia, you know, or maybe Alzheimer's or some sort of memory impairment that have a very difficult time, like with bathing or showering. It's so difficult, and they're combative. And our CNAs, like, bless them, they take a brunt of that, you know, because they really want to have that happen. And so one of our social workers researched in Europe that they had incorporated singing by their CNAs, that rather than Ativan and all the other drugs that we would do that would make them sleep all day and much more difficult to manage then from a healthcare perspective. And it works 100% of the time. It's crazy. And it doesn't have to be, I mean, they're all beautiful singers. I think they're all beautiful singers. But they sing things like Happy Birthday or You Are My Sunshine, like something that is very familiar.
Do with kids.
Right. And that brings
Yes.
people right down to a calm, peaceful place, and they're easy to get into the shower and bathe. And I just think, well, everyone should know that. But most people think you're crazy when you tell them that that's what works. They're like, yeah, it's luck. Like, really? You can't be lucky.
And my experience is that, yes, there are people that are skeptical and I may or may not ever see them, but the ones that are open to it to begin with, or the ones that are not sure but will take a chance, you know, I continue to go to see them. It's not like they say, well, this isn't really working for me. It's very rare that happens. So, and the other thing, of course, is just the combination of different people, you know, the team coming into their homes. It's complementary. You know, we complement each other, and it creates something larger than the parts.
But I love it when patients start calling and saying, well, this week, I really don't need to see the nurse twice, but I'd love it if the massage therapist, Novelle, and if Lawrence or someone, you know, if we could have more of these other visits, that would really work well for us. And it's like, yes, score. And then being able to teach family how to incorporate some of that stuff too is a really good tool.
Yeah, and you know, I just think that crisis thing comes to mind just because I think we're all like that. So when a nurse is somewhere where there's a crisis, she's going to go to medications first because that's her training and experience, and she's seen the most success with that. Whereas someone who's a massage therapist is probably like, oh man, let me get my hands on that person. So we all have what we know works, and that's the huge benefit to having a whole team, because someone can go in and say like, I am at my wit's end, I don't know what to do. And then Novelle and Joe will be like, let me get my hands on them, and Lawrence will say like, let me go, you know, play for them, and our chaplain will say, is it spiritual distress? Like, what can I do? So it's nice to have all those hats at the table to help. It's so cool. It's the coolest thing. We're really lucky.
Do you guys think though, when we sat down and did rework that booklet, Cancer Resources, it used to be very much like, here's your home health provider, here's your DME provider, here's the doctors in town. And now there's fitness programs and yoga programs, and let's talk about wigs so you feel pretty again. And I really feel like there is a shift coming for cancer care, and really anybody that's sick could pick up that book and really benefit from it. It's not just cancer specific, a lot of it, but it's really getting back to hopefully that whole body wellness and what that looks like.
Yeah, and I think palliative care, the definition of that really encompasses that. It's really everything. It's spiritual, physical, emotional, family relationship. It covers it all. I really agree. Yeah.
I think the hardest part with getting people is they don't, even though you can sit there and tell them all their resources, they don't access them. That's a big frustration for me, is just people not taking advantage of all
Why do
these
you think
great
that
things
is?
out there.
What do you think keeps them from it?
Not wanting to maybe change a lifestyle thing. It's just like, an alcoholic could not quit, making them quit drink. You can't do that. I can't make my obese breast cancer patient that because she's obese, it's feeding her breast cancer because fat cells make their own estrogen. I can't make her diet and exercise, and I can give her all the resources in the world, but if she's not going to take them and do something to change her situation, then that's where I get really frustrated. Things like that. And Missoula, we have so many. I got a call this week that Red Willow was sponsoring a horse workshop. I'm like, how cool is that?
So at the pain conference that Red Willow was at, I had heard a speaker talk about motivational interviewing, which I had not ever heard of before, which is crazy now that I've heard of it. But it's the idea that some people aren't ready to make those big life decisions, and the more people push to make them, the more they're not able to, because it becomes about that. So the idea with motivational interviewing is finding what are your motivations for why you'd want that change, and just starting to work on those things that are manageable and not worrying about the change. Hopefully your motivations grow so much over the time you're doing it, all of a sudden you look at that change and you go, I got this, I can do this, I'm going to make that change. But when you're facing financial stress, when you're facing grief of loss, when you're facing a body that doesn't feel good, medications that make it harder, and just tiredness, I think that those are a lot of the really challenging parts to making big lifestyle changes. That
it's just overwhelming, right? So it's hard to, it either really motivates people to make a big change, or they get frozen in it.
Yeah, I always think of body image too.
it's huge.
Breast, neck. I always feel so bad for like the neck and the face cancers, and I think how distressing that all has to be. I know breasts are kind of a thing too, but that's disfigurement.
You can't cover the face as much.
Yeah.
And I think that's why a lot of people, a lot of my ladies anyway, they're more fearful of chemo and losing their hair than they are of their breasts. It's pretty, just because you can't, that labels you. That you could see that a lot easier. You can cover the breast thing up.
Well, I'm aware of the time, and I want to come back to, Emily had a question when she came. She said that she works with a lot of people with cancer, but she doesn't really, it's hard to know how to talk about death with them. And so I wanted to open that up to the group and say, when you're working with a cancer patient, how do you broach the subject? What's sensitive, what's not sensitive about the whole, just like the oncologist faces, are you encouraging them to fight? Are you encouraging them to think about, are they thinking about death? How do you talk to people? It's a really good question.
This is the ultimate question. I think that we all struggle with. That's so hard. We just had a death cafe, and we do that every Wednesday, but the one we had last month, we talked about that pretty specifically. How do we talk to friends? Because I have a friend who's going to see one of her best friends that's dying from cancer, and she was just like, I don't know what to go say to her. Like, do I go say, call hospice? Like, do I? And she went and she couldn't even have a conversation even though she really wanted to, because it wasn't something that the person wanted to hear or could hear. And, my mom is the one who started Hospice in Missoula, and she said, talking about death when you're in that position is like looking into the sun. Like, you can't do it. Like, it's too painful to do it. And that's why people avoid it. You can do it for a second, You know, you could like look at it for a second and be like, yep, that's gonna happen. But then it's so hard to do that when you're in that place. And so that's why we talk about like talking about it ahead of the game. But when someone is facing that sun so right on, it's really hard to address that in a delicate way. I mean, I think we all feel that way. I would take pointers from people too. But social work would be the best place for me to go. That's where I would go.
I just started like, what are you afraid of? And so it's asking the question without saying, so you're gonna die, how does that feel? You know, no one's ever gonna be warm to that. But the question of what are you afraid of really addresses, for some people it might not be the death. It might be my kids being here without me. That's what I'm really afraid of. And it kind of opens up that door to say, well, it's scary to think of them being without you. What's your relationship like with them? And it makes having the conversation about the thing that's scary not so unmanageable, because it's not just about the dying. Some people are afraid of the dying, but some people will say, I'm worried about suffocating to death. Yeah, I'd be worried. That sounds terrible. Like, who could we talk to about that to get more information and more education? Because if people stay in their state of fear, the trauma studies, everything shows that as soon as you are afraid, you move to that part of your brain where you cannot do anything but be frozen and stuck in it and alone in it, because nobody can go and be there with you. You're just busy being in that survival mode. But the second you can get out of that scary word death or whatever you're afraid of and come back to the place where you can talk about, I'm afraid of my family being without me. So it's your family time you enjoy. What type of family things do you enjoy? We love the garden. Oh, the garden's great. Seasons, it facilitates a conversation about seasons. And we talk about, well, when you're gone, what do you want them to remember you by? And that becomes the legacy talk. And how do we put your story down in words that is something they can carry with them and help them remember that, gardening and growth is something. And it leads you. You don't have to talk about it. They take the conversation for you. But those are two great questions. What brings you joy in your life? Let's do more of that. What are you afraid of? Let's make a plan for that.
What's the work that you're doing?
I work for Fight. We do exercise groups for cancer patients and survivors.
Do you have time to talk as a group while you're doing that, or is it just hit and miss?
No, we break it up. So the first half of the session will be like a group exercise, so you'll learn something new. And the second, we kind of set everyone free, in like the weight room and the cardio deck. So it does give a lot of time for people to talk, like while they walk around the track. It's normally when we start talking to a lot of people.
Where are you located in?
I'm at the Peak Health and Wellness Center on Blue Mountain. It's where we run. Currently, we're trying to expand to more Missoula places.
Just what's your biggest concern is often a really non-threatening question to ask. They might not tap into death at all, but it opens things. And I like to do that in a family setting. And it's pretty, one time it's like getting the storm windows on. The man's dying, but his biggest concern that day was it was getting winter and how are the storm windows going to get put on. So you just don't know. And in a setting like that, it seems like that, what's your biggest concern?
Yeah.
Might be helpful.
And it's great because that setting, we don't make it, it's not supposed to be a support group focused group. It's focused on the exercise. And so people can kind of bring to it what they want. But some people they just need to talk about it a little bit more.
Golly, I think exercising is the best excuse for a support group. For me, I'd probably be like, yeah, I'm going to exercise, and then I would talk. Because I don't know that a support group would appeal to me. I wouldn't be like, yeah, I think we'll go to a support group.
Yeah.
So you probably have
it's
that.
like a good outlet,
Yeah, whether you want it or not, that's going to come your way.
And when I first started working, I didn't realize that I would spend so much time talking to the cancer patients about their cancers and their lives. I thought it'd be more exercise-based, but it really has opened up to be so much more, and it's really interesting.
Yeah. I love that it's a way for them to connect back with their bodies in a positive way, because so many people that have diagnoses inside them end up with this struggle of wanting to hate their body for doing this to them, yet it's the body that brought you to life. And so how do you connect back with your body in a way that feels good? And the studies show that one of the easiest way to get the grief and the stress hormones out of your body is to exercise. So we've talked to the Y, and the Y is interested in doing, what should we call it? Like move your feet, help your heart sort of idea. And that it's not your typical grief group. It's the idea of going and working it out. And so it's not necessarily just cancer specific, but bigger than that. But same idea.
I believe it could reach to a lot of other areas, not just cancer. Yeah. Because, I mean, you see it just so much, just even with just people that don't have any diagnosis of anything, just they're just gloomy, they just don't feel like they have the energy or that, and if they just get up and move, it just really, it's kind of like their body just flushes all of that out, and it really kind of helps boost the spirit, and we see that a lot with our cancer patients. It really just helps them kind of get their mind off of cancer. I think everywhere else is like cancer, cancer, cancer. And this one's like, you gotta stand up straight. Yeah. Like, are you having good posture? I don't care about your cancer. Tell me about your posture.
Dean Ornish is a famous cardiologist, and he did a lot of research, on the medicine and of the heart. And his transition, as of late, has been more to bringing in mindfulness and practices like that. And Dina Sadi, who will be here next month for conversations, she actually is piloting an initiative with the Heart Institute to start incorporating some of his best practices into their heart patients on the floor. And so I think that people new to the field can come and talk about what's so important, but when you get people who have been established and respected as experts, all of a sudden, Dr. Speckerts of the world saying there might be more to this if we look at complementary or things that don't have to just be pills. Pills are so important and we love them, but there's more that can make a whole body function well.
Do you want to talk a little bit more about what next month?
So she'll come. She's from Red Willow. She has her practice at Red Willow, where they do a number of different classes specific to yoga for chronic pain, yoga for bodies that don't do yoga well. Like that's perfect for me, but trying to expand for people to be able to not just think yoga is for people who are yogis, and mindfulness and coming to breath is what she'll talk about. And Dean Ornish as well in some of his study with the heart information. And there's yoga for veterans, and that's especially focused on PTSD symptoms. And
that just brings up like super funny.
Right, combat boots, downward dog.
Yeah.
You can just
They
see
have
it.
camel mats.
Yeah. Camel mats.
Dogs, right down, go. I'm show for that.
So they'll be here next month.
That's cool.
Yeah.
So
Is it Dean Ornish? I don't know.
Dean Ornish.
Ornish.
Dr. Dean Ornish.
the
He's
date?
next month will be the second or the third Thursday of the month. I think it's the 19th-ish. I don't know if I'm going to check that.
Thursday.
Third Thursday up here. And then the second Wednesday, you guys are all welcome. This is more of a scheduled format on what our topic's going to be, but our Death Cafe is really fun to do. Why we call it Death Cafe, we really talk about like life and what makes life, make death not so scary. And they take on their Death Cafe, they do it in Europe and Eastern part of the States, and it's a really common thing. So we drink coffee and we just have open conversations.
Our meeting is second Wednesday, so.
Yeah.
And
Oh
this
my God,
kind
it's so
of
much fun. You have to
same
just come
hour.
Is it the same hour too?
Well, yeah, we meet from noon to 2, and we're out there, so it's just hard for me to get, where are you meeting right now?
Cafe Dolce on Brooks.
Okay,
10 till
yeah,
12.
Yeah.
From 10
Come for an hour.
Yeah.
To an hour and a half, yeah.
So things to look forward to. Well, thank you. This has been a fascinating conversation. Thanks for coming, but it's beautiful out. We still have time for sun, so let's call it quits for tonight.
Thank you so much for coming.
Thank you, guys.
Great information.
Thanks.